Hi everyone, my name is Gurja Basra and I'm the Manager of Patient Programs, Research and Advocacy here at Lymphoma Canada. I'm very pleased to welcome you all to this breakout session on Hodgkin lymphoma. Before we start, I just want to go through a few housekeeping items. So this Zoom software does not allow you to access chat features or turn on your microphone. So if you have a question, the session will be followed up by a live Q&A session. So please keep your questions in mind and please be sure to attend the Hodgkin lymphomas Q&A. So to introduce our speaker today, we have Dr. Joanne Hickey, who is a hematologist with Newfoundland and Labrador Health Services, and she's an associate professor with the Discipline of Medicine at Memorial University. Her academic interests focus on medical education, working with both undergraduate and postgraduate programs, implementing curriculum innovations to improve the education of new physicians. As the former medical director of the Newfoundland and Labrador Cellular Therapy and Transplant Program, she has a particular interest in the treatment of Hodgkin's lymphoma. So thank you, Dr. Joanne Hickey, for joining us today, and you can get started as soon as you're ready.
Thank you so much for that kind introduction, and thank you very much for the invitation. I'm really excited to be able to chat with all of you today about Hodgkin lymphoma. So just some disclosures, I have done some advisory boards with Gilead and Celgene, and we'll get right into the talk. So three main things I hope that you take away from the end of today. So I really want this presentation to kind of give you a language to understand your patient, you as a patient or as a support person, sort of the patient journey in the context of the biology of lymphoma and sort of the information that we as physicians and a healthcare team use to make treatment decisions and gather the information that we need along the way. So at the end of this presentation, I'm hoping that those with us today will understand the basic biology and genesis or creation of Hodgkin lymphoma. Will understand the rationale behind testing, particularly pre-treatment testing in Hodgkin lymphoma, and then of course understand the rationale in treatment decisions in Hodgkin lymphoma, and understand that there's a variety of different ways to get to hopefully a good end outcome. And that our treatment decisions are individualized based on data, but also on the patient, very importantly, that's sitting in front of us. So I think I just wanted to start right back at the beginning. So what is cancer? Just to kind of put ourselves all on the same playing field. And I find even physicians sometimes we need to get back to basics to kind of remember what we're dealing with. So cancer in general is a term for a disease where you have abnormal cells. The cancer cells are dividing without control. Normally, our body is full of checks and balances to make sure that things grow enough, but also not too much. It's like the Goldilocks, right? Cancer is when those switches are turned off or on, and the cells are growing without control, and then they can invade or damage nearby tissues, and that's from the National Cancer Institute. And the type of cancer, so people will hear about like breast cancer, lung cancer, lymphoma. So the type of cancer depends on where the cancer starts. So what was that normal cell before it became cancerous, before it became abnormal and started growing uncontrollably? So lymphoma. A lymphoma is a type of cancer of the blood and the immune system. So the cancer cell in Hodgkin lymphoma is over here. It's one of these little B cells. So what this little picture shows is sort of what's going on in the bone marrow, which is your blood factory, where all your different blood cells are formed. You start back here with these stem cells, which are like baby cells. They're like I say, seeds for the bone marrow. Everything grows from them. Then you get the lymphoid and the myeloid side. All your sort of normal blood components grow over here. And this is sort of the main immune system workhorse over here in terms of the lymphoid. And it's this little B cell that is the problem in Hodgkin lymphoma. And I think it's also really important to remember that the organ involved in a lymphoma is the lymphatic system, and it almost lives throughout, it does really live through your whole body. So you see all these little green dots are lymph nodes, where normal immune tissue lives to fight infections. They are all these cells circulate around through these vessels. You can see the bone marrow where these baby cells are born can have lymphoid tissue in it, and all your organs have lymphoid tissue as well, or most of your organs. So, it's when you look at blood cancers like lymphoma, we think about them in a bit of a different way than we do in other types of what we call solid tumors. So, like a breast cancer or a bowel cancer or something like that. So, what is Hodgkin lymphoma specifically? So, even amongst lymphomas, Hodgkin has a bit of a unique pathology and biology. So, when we talk about pathology, we're talking about, if we take a piece of a tumor and we look at it under the microscope, what do we see? And that's what we're seeing over here. So, the cancerous cell in a lymphoma, in the Hodgkin lymphoma, as I said, is a B lymphocyte origin. And it's this little fella here, and it's called a Reed-Sternberg cell. So it's also sometimes called, to medical students and pathologists, called an owl eye cell. You see these two almost looks like little eyes. So those are what we call nucleoli, which are special changes that happen in a nucleus of a cell, but it's very distinctive looking. And that Reed-Sternberg cell starts as a B lymphocyte. And Hodgkin lymphoma is a little different compared to a lot of cancers. In most cancers, the tumor is all the cancer cell, right? So you'd see a ton of these just in a big sheet. Here, though, the cancer cell is actually, and so these little Reed-Sternberg cells are these fellas here, and you can see there's not a lot of cancer cells compared to all this other stuff around it. So it's surrounded by inflammatory. So all these little tiny blue dots in here are all normal immune cells that, though they're helping to support the cancer. And then there's also lots of scar tissue or fibrosis in some of these types of Hodgkin lymphoma. And so that's what this pink stuff is here. So, a little bit of a unique biology, but it's important to understand when we get to testing and even to treatment. So there are, in general, two main categories of Hodgkin lymphoma: classical Hodgkin lymphoma, which has these variety of subtypes, and nodular lymphocyte predominant Hodgkin's lymphoma. Today, we're going to primarily be talking about classical Hodgkin lymphoma, and these different subtypes are all staged and treated in the same way. Nodular lymphocyte predominant Hodgkin's is a little bit different than classical Hodgkin's, and over years we've learned that it's actually probably more like a non-Hodgkin's lymphoma than Hodgkin's, although a lot of treatments are similar to classical Hodgkin's because for many years it was kind of lumped in with the classical Hodgkin's category. But we're not going to talk about that as much today because it lives a little bit in a world on its own. We're going to focus on classical Hodgkin's. So the next thing that patients often want to know is what causes my lymphoma, what caused my cancer. So for all cancers, in terms of very basic principles, what causes a cancer is a mistake, right? So people hear about genetics and mutations. And I always tell people that a genetic change or a mutation doesn't necessarily mean it's a genetic disorder from the perspective of it being hereditary. Our bodies, all of our bodies, have genetic changes and mutations happening all the time. Mistakes can slip through. But our bodies also have normal mechanisms, primarily through the immune system, to catch those mistakes before they cause the problem. So what happens in a cancer is those mistakes slip through. So the body doesn't catch a mistake, and enough mistakes happen so that, again, the cancer cell has a permanent on, it's growing too much, or its off switch is broken, it can't die. And that's what causes cancers to grow and to invade, right? Sometimes people wonder, like, is something, can this be inherited? Or family, is there are cancers inherited when they hear genetics? Certain types of cancers, like breast cancer, some breast cancers, we know very specific genetic mutations that can be inherited from one person to the next. And that's more of a heritable cancer. In Hodgkin lymphoma, although we certainly see clustering in families sometimes, there's no known gene that can be inherited from one person to the next as of right now. The work is still ongoing on that. But as we talked about, there's still going to be some sort of mutation. So this is where we have this germinal center B cell. we have some sort of a transforming event. And again, in cancer development, so mistakes can happen, but certain things can cause more mistakes. So an example that many people know about is, for example, the link between smoking and lung cancer. The reason smoking predisposes to lung cancer is it causes way more mutations by damaging all those cells in the lungs, and there's a much greater likelihood that one of those mistakes is going to slip through. So in Hodgkin, we don't know all the possible transforming events, but there's one sort of potential link. It's this thing called EB, Epstein-Barr virus, which is a virus that causes infectious mononucleosis. So those mutations happen, and this abnormal cancerous Reed-Sternberg cell is born. That Reed-Sternberg cell loss of apoptosis means apoptosis is when a cell normally dies. It means it lives a long time. It doesn't die normally. So that's one of the things that means it's growing out of control and can take over. And it also releases these things called cytokines, which are like chemicals that help the other cells grow. So these cytokines causes what we call inflammatory response. That's what causes all those cells that are around the Reed-Sternberg cells. And then that inflammatory response actually sort of supports the Reed-Sternberg cell, those cancer cells. So it's like a cycle. So we talked about risk factors. So one potential thing that can cause mutations is like an EBV virus or potentially other viruses. Also immunodeficiency. So we talked about the immune system fights infection, but it can also help prevent cancer from the perspective that it can identify some of these abnormal cells and get rid of them before they turn into a true cancer. So anyone whose immune system is not totally normal has an increased risk of cancers, and in particular lymphomas. So some people can be born with an immune deficiency after they've had a particular type of organ transplant. They're on medications to suppress their immune system to prevent rejection. Patients with HIV, that is not well controlled, right? Hodgkin lymphoma is a fairly rare cancer on a large scale, but certainly as hematologists, we see it quite frequently. But it's only about 0.5% of new cancers per year, and it's estimated that there'll be about 1,200 new cases in Canada in 2024. So the next question I have is, how do Hodgkin lymphoma patients present? So that's present is medical lingo. So what symptoms do patients develop that cause them to seek medical attention? So, most of the time, the Hodgkin lymphoma starts in lymph nodes. As I said, it can happen outside the lymph nodes, but mostly it's in lymph nodes, and it usually travels from one area to the next to the next. So you can patients sometimes will find a lymph node and an enlarged lymph node and go to the doctor. Sometimes people will also get symptoms because of those lymph nodes. If they have really large lymph nodes in the chest, they can get some pain, cough, short of breath. In the sort of down in the belly or in the groin, they can get leg swelling. Up under the armpit, they can get arm swelling, belly pain, back pain. And the other thing people can get is what we call B symptoms, and it's due to sort of those inflammatory cytokines released by the cancer, and that's drenching night sweats. So that's not just I'm sweaty because it's warm. It's the middle of the night. I have to get up because I've soaked through my sheets or my pajamas and change my sheets and pajamas. Fevers or weight loss, unexpected weight loss that's not intended. So how are Hodgkin lymphoma patients diagnosed? So this is where understanding a little bit about that pathology is important, because there's a variety of different ways, to get a diagnosis of a cancer. We need to get a piece of that cancerous tumor, and we need to look at it under the microscope to see is it cancer or not. So there's a couple of ways to get that tissue. So one over here is called a guided core biopsy. So this is the lymph node under here, or this is what the lymph node looks like magnified. And this is what the lymph node actually looks like with the ultrasound. This is that ultrasound probe where they kind of, put it on your skin, and the ultrasound waves give us a picture. So we can see the lymph node with the ultrasound, and then we can use a needle to go in and take a piece of that lymph node, take it out. So you're going to get a tiny piece and look at it under the microscope. Okay, so the advantages are, sure, anybody who's looking at this says that looks relatively easy. A needle, go in, have a piece. Depending, of course, where the enlarged lymph node is, if the lymph nodes are in the chest or in the belly, This would be a little bit harder, but would certainly be easier than what we call an excisional lymph node biopsy. So that's where a surgeon usually would go in and actually cut out the whole lymph node, and then we'd have that whole lymph node to look at under the microscope. Obviously, this is a more invasive procedure and would particularly be more invasive if the lymph nodes are not close to the surface, like this one here under the armpit. If this was, in the belly, in the chest, this might actually even require an operation. Why, you might ask, would we ever even consider doing something like this when we have something like this that is so minimally what we call invasive? Remember that tumor. This is where it's important, right? In order to diagnose this cancer, we have to see this little fella. And this little fella is a very classic Reed-Sternberg cell. And they don't, again, no lymphoma is exactly the same. Those cells don't always look quite as pretty and obvious as this fella. So, if you have a needle that's just going in, you could imagine it can either miss those cells or not have very many of them. So if it goes through here, you're just going to get all that normal looking stuff. Or if it goes through here, you're not going to get anything. You're just going to get scar tissue, right? So there's a possibility of missing the cancer, particularly with Hodgkin lymphoma. This is a tough thing, those core biopsies with any of our lymphomas, but particularly with Hodgkin lymphoma. Whereas if you get a great big piece like here, then you have much more to work with. You can see all of the different cancer cells. You can see that inflammation, etc. Okay, so this is why some people will require multiple biopsies to get an answer. Sometimes people will have a couple of those cores, and then they finally have to go to a surgeon and get a lymph node taken out. So that's kind of why that can happen and why we try and make decisions certain ways. So how is a Hodgkin lymphoma staged? Of course, everybody wants to know, understandably, what their staging is. And if you're looking at anything on TV or any media, there's always lots of discussion about stage in cancer. So, what is staging? At a very basic level, it describes the extent of the cancer. Where is the cancer in the body? It's a language that allows your healthcare team to sort of almost have like a shorthand to say, where is the cancer, and then to give you that information. Remembering, of course, when we talk about stage, just to bring back this picture, just to highlight again how these lymphomas and blood cancers are a little different from how we think about solid tumors, like again, a breast cancer or a bowel cancer or a lung cancer, where it really starts just in one spot and then spreads, right? So the idea of stage, when people hear stage 4, it sounds very scary, but that comes a lot from understanding of cancer from solid tumors, common solid tumors, where when you get it early before it is spread, you can cut it out and not necessarily need more treatment, but it's much more complicated if it's in multiple places. Lymphoma is different. This, remember, is the organ. The whole body has places where the lymph nodes live. So most of the time, or very commonly with lymphomas, we'll see cancer in multiple spots. And it's one part of what we call prognosis, or our ability, our chances to cure a cancer, but it's not the only thing. So in Hodgkin lymphoma, this is how we kind of do staging. Stage 1 is you have enlarged lymph nodes in one spot. That's it. In one spot is stage 1. Stage 2, you have enlarged lymph nodes in more than one spot. It can be more than 2, but it's all on what we say, the diaphragm here. The diaphragm is the big muscle under your lungs that helps you breathe. It's what makes your lungs bigger and smaller and gets air in and out. So stage 2 is if all of the lymphoma is still in just lymph nodes, but it's only on one side, so either in the chest or down here in the belly, so one side or the other. Stage 3 is the lymphomas on both sides of the diaphragm. So you can see it up in under the arm, the axilla, what we call cervical or neck, and here it's in the belly and maybe in the groin. So that's stage 3. Stage 4 is when it's outside of lymph nodes, and one of the most common places is in the bone marrow. Remember, bone marrow is a place where lymphoma cells or lymphoid cells can live. Okay. So the test that we need to do to figure out that staging is we do blood work, which gives us clues about organ function and what might be involved. Very important, our history. There's no test that can tell us B symptoms other than what the patient tells us. Have you lost weight? Do you have drenching night sweats? Do you have fevers? And those B symptoms are part of our staging. So just to go back, so lymphomas are either stage 1A or B. A means you don't have B symptoms, B means you do. And you only need one B symptom for it to be a B. Same thing, 2AB, 3AB, 4AB. And then probably one of the most important tests in staging, and it's also become important in treatment, is this PET-CT. So it's called functional imaging. So what a CT scan is, it shows anatomy. It shows like basically a snapshot, a picture of the inside of the body. It's just like a picture. And it can show if those lymph nodes are enlarged or if there are other tumors of lymphoma in other places, but it doesn't give us any idea of activity. The PET part of a PET CT is so cancer cells are what we call more metabolically active. They're hungrier and they take up more sugar. So with a PET scan, we inject a radio labeled radioactive glucose, not dangerous to the patient, or sugar, glucose is sugar, that's injected to the patient. And then those cancer cells are going to gobble that up more. And then that radio labeled glucose will sort of light up on the scan. So it can also show activity. So that's what we talk about it being functional. And this is really helpful because not only does it give us a more accurate picture of where the cancer is likely at the beginning, it also helps us determine how well our treatment is working. Because, for example, we showed you like there's lots of scar tissue in a lot of these lymphomas, and that scar tissue is not going to go away with chemotherapy. So commonly before we had PET scans, we were left with a lump. So the tumor may have shrunk, but it wasn't gone back to normal. And it was really hard to estimate whether there was any cancer left behind or what the chances are of cancer being left behind. But a PET scan now can show us activity as well. So if the activity's all gone back to normal, it's much more likely that's just scar, and we have a much better chance that that cancer is cured. If there's still activity in there, it's much more worrisome that there's cancer left behind, and we have to think about doing something else. So this is what a PET CT can look like. So the black spots are areas where that glucose is being taken up, okay? So we do know that there are certain areas where it's normal to have increased uptake. So as an example, in your urine you do, because that's how you excrete that, it's not more uptake, you're peeing out that radio-labeled glucose. So these are actually in your kidneys and that's your bladder. So this stuff is normal. The brain always takes up lots of sugar. So the brain always lights up. So the brain is always quite dark. So here in a stage 1, you can see this is the lymphoma up here in one spot. In a stage 2, you see 2 spots, this big spot here, and then this spot here up closer to the neck, but again, all in the chest. Stage 3, you're seeing multiple spots on both sides of that diaphragm. And then stage 4, pointing here, that's your hip bone. There's also bone involvement. So here you can see in the bone, and this is where it's lighting up in the lymph nodes. So just to get a sense of what kind of pictures we're looking at, or our radiology, nuclear medicine colleagues are looking at when we're, making decisions. In general, when we're talking about treatment of lymphoma, of Hodgkin lymphoma, I should say, we look at limited stage, meaning stage 1 or 2, versus what we call advanced stage, stage 3 or 4. And, we have basically different treatment approaches, depending on what the stage is. And that's come from clinical trials, which we'll talk a little bit about now in a minute. So why is staging important? Of course, prognosis is prognosis, or what is the chances of cure, right? That's what people want to know. What are my chances of success? I love this lady down here. I always talk about prognosis is like our crystal ball. Trouble is, prognosis comes from, we give numbers about chances of cure, 50%, 70%, 20%. Prognosis and those numbers apply to groups of individuals. Unfortunately, we have no way to know for sure what's going to happen on your journey, patient's journey. Their cancer is going to be their cancer. But it is really important in helping us make treatment decisions. And it's always important to remember that, particularly lymphoma, staging is only one of many factors of prognosis, and that all stages of Hodgkin lymphoma are potentially curable and potentially highly curable, right? So it's important to us, but it's largely important because it helps us to make treatment decisions. So you get different treatments for limited stage versus advanced stage. And it's also very important to know where the cancer started, to know if it looks like it's all gone to the best of our knowledge at the end. So now sort of probably what people really are interested in is, how do we develop a lymphoma treatment plan? So it's really challenging because, as I said, we have to take all this, what we call data, so information from clinical trials done with different patients, different centers all over the world, try and cohesively put that together and then use it to treat a patient and to counsel a patient and talk to a patient about what we're doing. So I just wanted to give a little information on sort of what is a clinical trial. People have heard about it. Often people think about clinical trials more about as a, if people are going through a cancer journey, they're thinking about a clinical trial and can I participate in a clinical trial? But all the information that we get about what is the standard treatment, what treatment you're offered, comes from clinical trials that were done in the past, right? So it starts with research because, we have to have a safe and robust way to test treatments, to find new and better treatments, but also to ensure that we're protecting the people who are being tested on. So, it starts with exploratory research with researchers using the information about the biology of the cancer. So, I show that cartoon at the beginning showing how a cancer develops. Well, those cartoons get very complicated with all sorts of different biologic pathways, and researchers can identify, we learn how a cancer grows and how a cancer is formed, and then researchers can use that to try and find like off switches or on switches to help fight the cancer. So we start with that. Then there are preclinical studies in animal testing and lab research. Then phase 1 is when it's tested initially in healthy volunteers. Is it safe? Are there side effects? Phase 2 is when the medicine is used in patients who have the disease. And often these, again, you're looking at for safety primarily and effectiveness, and then you can use to see how effective this work is. Does this work, and is it worth moving into the next phase, which is phase 3, where we actually compare one treatment to another. Phase 2 studies are often more in patients who have what we call refractory disease, don't have a lot of standard treatment options, and so you'll try something experimental. And again, these have lots of study before to give us lots of information to think that they are going to be effective, right? We never know till we test it, but it's done in a phased manner. And then, like I said, phase 3 is what we call a randomized controlled trial, where we compare to see which one is better. And then phase 4 is where, after a treatment has been determined to be effective, it becomes standard. We continue to study to make sure there's no new safety concerns and to make sure it continues to be effective. So a randomized clinical trial, or usually a phase 3 trial, patients are randomly assigned. So it means you take patients who all have similar cancers at a similar stage, and randomly, so it's like pulling a name out of a hat, one person will randomly get the standard treatment, which is what we already do and we know is effective, or the experimental treatment, which we've had lots of studies on and we have good data to suspect it's going to actually be better. And we're trying to prove that in these trials. And what we're comparing is remission rates. So does the cancer go to sleep? Of course, cure rates. Do we take care of the cancer completely? But also survival rates, because we have to think about side effects. So, if a cancer treatment is causing very severe side effects in the short term or the long term, so it might be it might be better at curing the cancer, but overall, because of loss of life potentially from side effects in the short term or long term, it might not actually improve on average patient survival. And again, that's why we work with averages, but then we have to apply them to you, to an individual person, or to your family member, or your loved one, or your friend. So clinical trials in Hodgkin lymphoma look at both maximizing treatment efficacy and minimizing the short and long-term side effects, right? So I like to think that we have gotten so good at treating Hodgkin over years. You know, cure rates in Hodgkin are quite high, that a lot of studies in recent years, even the last 5, 10, 15 years, have looked at de-escalating, pulling back, because we likely are over treating some people. Some people may be cured with less treatment. And so we want to minimize side effects. So that's what trials in Hodgkin are looking at. So as I said, it's a balancing act, right? So, you know, more toxic treatment might improve lymphoma cure rates, but comes at a cost of increasing side effects and toxicity. So as an example, in radiation, more intense radiation might improve lymphoma cure rates, but then there's an increased risk of second cancers or heart disease in the long term. And if you're treating, you know, Hodgkin's lymphoma is a common lymphoma in youth and 20, 30-year-olds, you know, you want to cure it, but you don't want the person to have a breast cancer in 10, 15 years if you can avoid it, or premature coronary artery disease, heart attacks, things like that. For chemotherapy, again, cure rates versus things, again, like second cancers, lung damage, and infertility, which is an important consideration for young people before they've started their family. So again, lots of exciting advances in treatment. You know, being a Hodgkin lymphoma treater over the last number of years and moving forward is a very exciting and exciting time, because we're getting better, I think, I hope, at treating patients. So PET response adapted is really important, because this is what has allowed us, it gives us that better tool to give us a clue of how well treatment is responding. So if you see people who are responding well, and again, we have clinical trials where we've tried something, compared doing the old way to the new way, yes, it works just as well. But we have found that you can actually de-escalate, so give a little less treatment in people who are responding early. And so you avoid unnecessary toxicity, but then you also identify those patients whose cancer is, I say stubborn, is not responding the way we want to early treatment. And so you can escalate, increase the treatment in some patients to try and maximize cure rates. And then the other exciting thing is targeted treatment. So old-fashioned chemo I describe as like a shotgun. So it's like you know, you get the cancer, but then it's like a whole bunch of shotgun pellets goes out, and you get a whole bunch of other side effects as well. Whereas targeted treatment is more like a sniper rifle. You're targeting the treatment at a specific biology point in the cancer's life cycle. And so it's more like a sniper rifle. It's not perfect, though. There are definitely still side effects, or what we call off-target effects. But overall, these treatments tend to be more effective and have fewer side effects, and we're incorporating them into our standard, very effective old-fashioned chemotherapy. Again, the challenge here is that all of that data must be applied to an individual, to that person, so sitting in front of myself or one of my colleagues in a clinic. Again, just highlighting how different we all are. So what do we have to think about? This is just some of them. So you have to think about the patient's risk of side effects, and are we going to do more harm than good with the treatment? So we have to think about that. So other medical problems. So for example, some of our chemo can be hard on the lungs. And if people already have chronic lung disease, then we may make things worse rather than better, and we may change our treatment because of that. Similar to organ function, what medications are they on? How old are they? I made the comment earlier about the risk of second cancers. That's going to be important for everybody. But if that risk of second cancer is measured over 20 or 30 years, it's going to be more important to consider in a very young person than someone who is more elderly. We have to think about the patient support system and what helps they have to get them through this treatment. And then very, very importantly, the patient's values. So what do you as a patient want to accomplish with treatment? What is most important to you, because some people, cure may not be the be all end all if it comes at a cost for their quality of life. And so those are the kinds of discussions that we have to have as we talk about treatment decisions. So now we'll talk about sort of treatment options in general. So when you look at this slide, anything that's in purple is what we call upfront treatment or treatment sort of at diagnosis. And then the options in green are things that we think about more in second line, or if a patient's cancer relapses, if your lymphoma relapses and comes back. So in terms of, so there's a chemotherapy alone approach versus combined modality treatment, meaning chemo and involved field radiation. Radiation alone, again, the mainstay of Hodgkin treatment many years ago, initially was radiation alone, and it is curative, but comes with lots of side effects as upfront treatment, but can be effective treatment in relapse. So in terms of chemo alone, these are the main three options that you'd see upfront, sort of standard treatment. This recipe called ABVD, and each one of those letters stands for a different chemotherapy drug, kind of old-fashioned chemotherapy drug. Then there's brentuximab. So brentuximab is a newer targeted drug combined with AVD. And then you have this escalated Bayakop, again, all sorts of letters, all sorts of different drugs. And as you kind of can guess from the escalated, this is a more intensive treatment than ABVD. ABVD has been the backbone of Hodgkin's lymphoma treatment for many years, and a lot of the changes have kind of come out from that. Again, in relapse, we talked about brentuximab can be used, but it hasn't been used up front. Other targeted treatment, pembrolizumab and nivolumab, and then also a technique called salvage chemotherapy with an autologous stem cell transplant. We'll talk about that a little bit more. So in terms of just again, get a sense of the side effects and things we need to think about, ABVD can cause nerve issues, neuropathy, certainly has a risk of infections, lung damage, heart damage. There is no significant risk of second cancer, and this is important compared to the old-fashioned recipe called MOP that this sort of came out of, had a very reasonably high risk of second cancers, and also that old one had a risk of infertility, whereas ABVD has a minimal impact on infertility or on fertility. Brentuximab, AVD, this is when we take the brentuximab and replace it with this bleomycin, replace the bleomycin with AVD. It has a higher risk of nerve issues because the brentuximab and this vinblastine can cause nerve damage. It also has a higher risk of infection, but it has a less risk of lung toxicity, lung damage, because that old bleomycin is hard on the lungs. Again, can still cause heart issues. And again, no significant risk to second cancers or infertility. The escalated Bayakop, so it has a much higher risk of infection, and importantly, like more old-fashioned treatment, does have a higher risk of second cancers and impacting fertility. But again, is effective, more effective than the ABVD in certain subsets of lymphoma patients who are proving to be, their lymphoma is proving to be more stubborn to our upfront treatment. Radiation, again, the risks is highly dependent on what organ is being radiated, but again, secondary cancers, you can get secondary heart disease when radiation is around the heart, so for chest disease, lung damage, again, from chest radiation. So just a quick note on the two main categories of targeted treatment. So brentuximab here is an antibody. This fella here is an antibody that directly targets a marker on the surface of a Reed-Sternberg cell, this thing called CD30. And what the drug does is it holds on to this MMAE, which is essentially a toxin. So that antibody is taken into the cancer cell, the toxin is released and causes the cancer cell to die. Then these immune checkpoint inhibitors. So this is very interesting because our immune system, I talked earlier about how the immune system can actually fight cancer, and it does. So tumors develop ways of evading, of getting away, of hiding themselves from the immune system. So this is the cancer cell up here, and this is your T cell. This is your normal immune cell. So this PDL2 and PDL1 are ways that the tumor hides itself from the immune system. So what this drug does is it blinds the immune system to these blinders. So it's what we say, it unblinds the cancer. It unblinds the immune cell. So the immune cell will target the cancer. So it blocks the tumor's ability to escape the immune system through this pathway. So I'm going to show you a couple of slides now to give you a flavor of options available in treatment upfront, and maybe why conversations, why it's so important that conversations happen with individual patients, because there's more than one way to do things, and to give you sort of a sense of why we might choose one treatment versus another. And it's always good to know in Hodgkin, and why we have lots of different options is because our clinical trials it's not just one group doing clinical trials. So there's groups all around the world doing clinical trials, and there are slight variations in how people treat Hodgkin's in different parts of the world. And so you'll see a different standard compared one to the other. So we have different clinical trials that we have to kind of put all that information together to decide what's the best treatment for any individual. So we have choices. So choices is good. Sometimes it makes it harder though when you have a choice in a treatment. So this is from the National Comprehensive Cancer Network. So this is American guidelines. I'll caveat that by saying there are certainly some differences in the US versus Canada versus Europe. There's subtle differences, but these are not the absolute most up-to-date version. This is a version, maybe the last one or second last one. But again, so don't take this as, this is what I have to do or what I should be doing. This is just an example of how we approach options in Hodgkin's, okay? So this is for early stage disease, and early stage disease, so that 1 and 2 can also, it's favorable. So there's other blood tests we can look at that tell us it's kind of a good player. And you'll see with earlier stage disease, in general, treatment is de-escalating. We're really looking at de-escalating because we have found that with less treatment, we can get just as good cure rates and then with better toxicity. All right. So you always start generally with a couple of cycles of A, B, V, D, then you get a PET scan. So this is where we talked about that response adaptive. This Dovell score tells you how well the disease has responded, tells you how much if the cancer is lighting up anymore. The lower the score, kind of the better. 1 and 2 is considered 1, 2, and 3 are kind of considered complete responses, but 1 and 2 is an even deeper response. 4 and 5 is when you're starting to get a little bit more into worrisome category. You're seeing persistent or even worsening activity. So if you have a great response after your first couple of cycles of treatment, then there's an option to do either combined modality, so with radiation, which was our traditional treatment, our old treatment, or with chemotherapy alone. So this is one of those de-escalating. So a couple of trials have been done that showed with just chemotherapy in people who have a good PET response, they don't necessarily need radiation, and they can get equivalent outcomes with chemo. So you might ask, well, why don't you just pick one? Why do we have a choice? Because again, if we think about those side effects, so say a young woman in her 20s that comes with a really big sort of mass, or we say tumor in the chest, we'd be worried about doing radiation there because of the secondary risks of breast cancer. Whereas if that same person was maybe 60 or 70-year-old person who had lymph nodes primarily in the neck, where radiation doesn't have nearly as many side effects and we'd be more worried about the side effects of chemotherapy, we might, or the patient might prefer to go with radiation. So again, options. Um, Again, this is a similar kind of thing, radiation versus just different numbers of chemo. And then down here, this is where you're worried, this is where you're looking at sort of escalating disease and worrying about, is the cancer really going away, or would we consider this refractory and we have to really move on. So this is for, again, early stage, but has a couple of these unfavorable characteristics. So again, a couple of cycles of chemotherapy, do your PET scan. If everything is looking good, then you go on to either combined modality chemotherapy, a few more cycles of treatment, plus radiation versus chemotherapy alone. And now we have, again, in terms of de-escalation, we have a trial that shows if your PET scan looks good, we can drop that bleomycin drug, which is really hurt on the lungs, and we don't like to give if we don't have to. Versus if your PET scan doesn't really show a great response, we're actually going to think about going to that escalated Bayer cup to see if we can get better remissions based on clinical trials. Okay. And then last, for advanced stage disease, so this is your stage 3 or 4, where your disease is on both sides of the diaphragm. So again, a couple of options here. You can do ABVD or backbone. You can do a PET scan. Again, everything looks good. You go on and you give more chemo, but you can drop that bad lung drug. If things aren't looking so good on your PET scan, there's still activity, then consider going up to that escalated Bayer cup. The other option, so that's one option. The other option in advanced stage disease now is this is where we're seeing these targeted agents coming, which is really exciting, where you can, and this is a pointing down here, so you can use that brentuximab with AVD for 6 cycles. Here it's not, we don't have PET adapted treatment as of yet. This is a newer treatment, but again, it has, equivalent on average long-term outcomes. Okay, so you get 6 cycles of that and get your PET scan. If everything looks good, then you just go on to follow up. If there's still evidence of disease, then that's where you're worried if the treatment hasn't worked and you have what we call refractory disease. And so the other fantastic thing about Hodgkin, so we have really good chances, really good numbers to show that we have a good chance of curing your disease first time around with our first treatment. But the other thing to consider is that we have very effective, what we call second line treatments. So if the first treatment doesn't cure your lymphoma, either it doesn't go into a good remission at all from the beginning, or it comes back some number of years later, which it certainly can, then we have treatments that can get it back into remission and have reasonable chances of even curing it in the long term. So the standard treatment is something called an autologous stem cell transplant. So it's a technique where we're able to give very intensive, what's called myeloablative or bone marrow toxic chemo. The chemo is the treatment. The chemo is very good at putting the cancer in hopefully a long-term remission. But the chemo is so toxic, it basically severely damages the bone marrow. We have to give back these stem cells, transplant them back, which, as I said, are like seeds to regrow the bone marrow after chemotherapy. As you can tell by hearing it, it's very toxic treatment. So not all patients would be well enough to be able to get through this type of a treatment. And it also has to be done, it only is effective, or is most effective, I should say, when the lymphoma is back under control with chemotherapy or targeted treatment. So, again, what if a patient's lymphoma comes back after transplant, or patients are not well enough for a transplant? We still have some good options that can provide good control for a good period of time, and maybe even a really long period of time in a select number of patients. So there's brentuximab we talked about, the pembrolizumab and nivolumab, radiation alone, and then this is where we get to those clinical trials, like phase 2 clinical trials, where new treatments are coming and might be available for patients. So again, considerations. We got to take all that information. We got to look at the person who's in front of us. We got to sort of look and see, their problems, their organ function, their medications, their age, their supports, and most importantly, give them information to help them achieve their goals. What do you want to accomplish in treatment, and what is most important to you? Again, all that data has to be applied to individuals. So thank you so much. Really appreciate your attention, and I really hope that you can attend the Hodgkin lymphoma Q&A as well.
Thank you, Dr. Hickey, for that informative presentation. Like Dr. Hickey mentioned, for the audience, please be sure to attend the Hodgkin lymphomas Q&A to have your questions answered live. Thank you, everyone, and see you there.